Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. Now, that same case that you're making a big U for, we also have the other tool that you're fondling over there,
yes.
which is
the Bougie.
Which is the Bougie. Yeah, it's the Bougie. And I don't know, personal opinion, but it's a rather indispensable tool. We were talking previous episode that you and I kind of selectively use it.
I will selectively use it. And again, that's just because I'm comfortable with it. I know how to use a Bougie. I've used it before, and it is my first fail when I'm in an airway. But sometimes when I take my first look, it might be this is a Bougie case. If I want to increase my chances of success, if it's complicated, I might just ask for my Bougie. Times I've ever asked for it before is when I've had anaphylactic patients or angioedema patients that I just need to intubate. I'm always reaching for my Bougie to be first.
Generally,
a preloaded.
Yeah, well, I was just going to say, generally it's not preloaded, and you have another provider passing the tube, but you can do it preloaded if you practice.
Yep. Mm-hmm. So, and there's different hold techniques and whatever you want to do. I don't wrap mine. I typically I have other people around me, right? So someone can make sure that tube doesn't come out. I can place it. I can drop this, and I can feed this in very quickly, right? But I've got more hands on board than you guys typically have when you're treating patients in the field.
I'll even transition, come off, and then put my tube on. I've tried practicing with a loaded with the tube load, and the balance is all wrong for me. It's something I do not prefer.
Sure.
So I'll just do any attempt with this and then whack my partner in the head with it, right? That little bent end there, you were talking about getting a little more anterior. Sometimes you can't get that tube to rise just into the glottic opening if they're very anterior. With this, you may be able to just kind of sneak it up and over a little bit with a much smaller diameter device, and then subsequently, pass a tube over it, or if you've already got it preloaded, just deliver it from there. Once you're bringing that tube down, there's a little bit of nuance to that too. You just don't go and just jam it in there like an IV catheter, right? You slide that down. If you feel it hold up at the glottic opening, if you feel it hold up a little bit, simply just twisting that on its long axis will just, that bevel will just kind of work between the cords, right? You don't want to cause cord damage, right? So if you meet resistance in the airway, generally the answer is stop. So stop, but you can kind of wiggle that through, if you will.
When a lot of classes will teach you exit stage left. So as you take the tube, you turn it to the left and point to the left, it'll come off and slide through a lot easier. Again, I think we talked earlier about sometimes you can know that you're in with this, because if it does end, you probably hit the carina. If it just sunk all the way, you're going to probably be in the belly.
Esophagus, right?
You may feel the cricoid rings as you pass, and it'll click. They call that the Bougie click. I personally haven't felt that.
Tracheal click.
Tracheal click also, yeah. Some of these do have, like you said earlier, they'll also have a trigger to raise the tip, coude tip. But just, again, know your equipment, know how to use it. These are awesome if you train with them. Yep. And it's just one more tool for the toolbox.
Yep. And then, as you were saying, you pass that, you can feel it ride down the. If you're using a straight one, you may not feel that with coude tip end.
Yeah, I personally have used these. I've never felt it. Have you?
Mm-hmm. It's not like running on a mannequin where it's like pop, 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 right?
If you feel it, I would think it'd be real subtle.
It is.
Maybe I just lost the sensation in my fingers. I don't know.
If you advance it basically until you stop, or you met a stop, carina or a little bit thereafter, that's called hold up, right?
Yeah.
And if you hold, it would stop somewhere in the lungs. That makes sense. Whereas if I was putting it in the belly, it's got a much longer, it's got a much longer travel down to the belly. So it would just like basically keep going, right? And that's what you were referring to is it keeps going. You're probably not where you think you are.
But
Certainly not where you need to be.
If you are intubating with Bougie, remember that is an extra step. Make sure that once you've passed the tube, you've already added an extra step. Get rid of the Bougie. Hold your tube tight till you've got accurate, that you know you've passed it.
Yeah.
And also, just if you have video guided laryngoscope, you should be keeping that in the entire time the tube passes. Once I get the Bougie where I want it, I shouldn't be removing that and then sliding the tube in. You should.
Well, the answer on the test is always going to be watching the tube
pass the cords.
Through the cords.
And the same applies. So.
Yep. So you should watch your Bougie pass through the cords. I take out my stuff, my handle, feed in my tube. I go back and you can look.
See that it's there.
Take a second peek.
Just to visualize it's in the right spot.
Absolutely.
Just to make sure that nothing funny happened.
And again, if you're dealing with somebody who's aspirating or vomiting at that point, you can leave suction in the corner of the mouth as I do this.
Sure, absolutely.
Or do you want to be extreme? Just slam it all the way down into the esophagus.
Or that. And if you miss, I mean, you bring up a good point. If you miss, leave that tube in the esophagus and go back in for your intubation attempt, and you'll see where the original one was.
Yep. If you can get a good mask, so obviously you're going to retreat at that point. If you can get a good mask seal with that hanging out, let's say if this is in the esophagus, if you can still get a good mask seal, and you might need 2 people for that case, right? You've done a couple of things. You've marked where not to go, right? But also, most, and I want to say all, because somebody is going to watch this and then go find the one piece of equipment that doesn't do this, but most suction tubing that I have come across will fit in the inside diameter of that airway adapter. It requires a little bit of coercion to kind of spin it and twist it in there. It's not like it's not meant to fit there. Turning this into a really nice way to decompress the stomach, if that was a case. The Decanto suction catheters, which are those large bore, right?
Those are very nice.
They are very nice, but if you need an even bigger one, right? Grab your 8.0 out of there and it becomes your super Decanto, sorry, suction catheter if you need it, right? But yeah, keep that in mind that you can often sneak it right in the inner diameter of that, rather than getting a soft suction catheter out and trying to weasel it down there. Yep.